So good morning again, everybody. I'm Michelle Hood. I have the pleasure of serving as the AHA's Executive Vice President and Chief Operating Officer. We all know that the challenges of sustaining our workforce predates the COVID-19 pandemic, but certainly the last 2 years have exacerbated issues and accelerated the predicted shortages. I can think of no better person to lead today's forum on this topic than our moderator, Dr. Melinda Estes. Dr. Estes is President and CEO of St. Luke's Health System, based in Kansas City, Missouri. And as Rick mentioned earlier today, when recognizing Mindy for her service as board chair, she served as board chair in 2020, that she leads with grace and skill as our field and the entire world faced the unknown. Those lucky enough to work with her know that she leads with heart. She emphasizes the important role her clinicians and staff have in caring for patients and the community. She's not afraid to confront issues, roll up her sleeves, and find creative solutions to complex issues. And I think workforce certainly qualifies as one complex issue. So please join me in welcoming Dr. Mindy Estes.
Thank you. I always have to adjust the mic. It's just the way it is. Well, good morning, everybody, and thank you so much for being here, and thank you, Michelle, for that introduction. I'm really delighted to join you today to host this important discussion. And as I look out at this room, obviously when we say what are the top 3 priorities in healthcare, and it's workforce, 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 I think that's very clear that all of you have taken a chunk of your morning to be here with us. Like all of you, I really experienced immense pride in our hospital and health system teams throughout the pandemic. Our field is filled with compassion and inspiration, but we also know that our teams are made up of people who are tired and overwhelmed, and that has and will only continue to exacerbate the workforce challenges our field is facing. Author Zig Ziglar said, "The greatest of all mistakes is to do nothing because you think you can only do a little." And I feel that's certainly the case with the complex crisis that's facing our healthcare workforce. Hospital leaders have developed creative strategies that are helping their organizations navigate current challenges and are strategically planning for future workforce. We have 3 of those leaders with us today for our panel discussion, and we're going to jump right in with a 2-part session. First, we'll hear the latest research from Dr. Erin Fraher, and second, a panel discussion with Mary Beth Kingston and Ron Werft on what's working now, what holds promise for the future, and how do we best support our teams throughout. So let's jump right in. Dr. Erin Fraher directs the Carolina Health Workforce Research Center, one of only 5 centers funded by the Health Resources and Services Administration to provide impartial, policy-relevant research. Her work is led by the question, what healthcare workforce is needed to ensure access to high-quality, efficient healthcare for the U.S. Dr. Fraher translates complex findings into practical takeaways and will share the relevant and necessary data to inform that strategy both short and long term. Please join me in welcoming Dr. Erin Fraher.
Good morning, and thank you for having me this morning to talk about my favorite topic, which is healthcare workforce. So hopefully these slides will advance. Here we go. So I'm going to take you, I don't know how many of you are David Letterman fans. I am a David Letterman fan. Thought we could all use a top 10. So we're going to do the top 10 forces influencing the healthcare workforce. And I'm really grateful. I have a student working with me, and I just want to acknowledge Jacob Rains. So one of the key messages that I'm going to take home today, and I hope you will too, is that you all faced workforce challenges before the pandemic, and the US healthcare system was undergoing rapid change. So it's hard to do, but try to take yourselves back to the pre-pandemic. I feel like everyone's brain's been erased, but let's try to take ourselves back. The number one challenge that we saw, even pre-pandemic, is something you talked about this morning, is value-based care, payment models changing. there's all of this experimentation going on, underway. And one of the things that keeps striking me, of course I'm a workforce researcher and I believe this, but we are paying much less attention how to redesign the healthcare workforce to align with this evolving system. And I don't know how many of you have looked at the papers around new payment models and the degree to which they're showing the outcomes that we want. Sometimes they're not. And I would argue part of the reason is we're not reconfiguring the workforce, and we need to think about that. And I sort of often envision it. I'm from Rhode Island, I do a lot of boating, and I often envision it, we've sort of got one foot on the dock and one foot on a boat, and it's just getting farther and farther apart. And if we want to be ready for that value-based care workforce and future, we got to reimagine care delivery models. We've got to reconfigure those workflows, redesign roles, upskill our existing staff. It's your existing staff who are going to transform care. We're also going to have some new hires. We're going to have to engage the patients. Patients are part of the team, and we're going to have to do this in teams. The second trend that I see in my research is because it's expensive to provide care in acute settings, care and the workforce are shifting outpatient. You're probably seeing this in your own healthcare system. More and more care shifting. We talked this morning about hospital at home, more shifting to the community. But where do we train the workforce generally? Inpatient settings. And so this is a place where we have a misalignment of training and where the workforce is going to be practicing. And this is so true of the nursing workforce. These are data from North Carolina. This is from a paper I'm working on. Most of the RN workforce is still employed in hospitals, but that workforce only grew by 2.9% between 2015 and 2020. Ambulatory care workforce grew really fast, by over 30%, and particularly that's registered nurses. If you look at licensed practical nurses who traditionally were not in hospitals, they're coming back. They're coming back, and they're also going into ambulatory care. So it's our registered nurse and our licensed practical nurse workforce that are really going to be the workhorses of our ambulatory care settings and hospital settings as well. And you see that hospital employment down 17% in my home state. And those trends are consistent with national data. If you look at, these are data from Alterum, and these are data sort of tracking over time ambulatory care employment. That's that kind of reddish line, hospital employment, the bluish line, and the sort of teal green is residential nursing home employment. And you can see that great hit that they had in ambulatory care and hospitals when the pandemic hit. But look at their recovery. This is all hospital employment, all ambulatory care employment, all nursing home across the nation. You can see these trends. One of my predictions is these trends are going to continue. We're going to see continuing decline in hospital employment and growth in ambulatory care. I do think that nursing home residential will rebound. So what does this mean? What does this mean? What are the challenges for you all, for the education system and practice? We really are going to have to develop more curriculum and clinical placements that better prepare nurses, but not just nurses, other healthcare providers, physicians and others. We see a growth in ambulatory care for physicians as well. And what are they doing in those ambulatory care settings? They're providing integrated behavioral health and primary care. They're doing all sorts of new roles in population health, complex care coordination, behavioral health, chronic disease management, geriatrics. We're gonna have to retool, reskill our workforce, and we're gonna have to do it in teams. We're gonna have to do it in teams. We're gonna have to share the care. And so these models are still evolving, and it's one of the things I wanna call to action today is help us understand what these models are. What do they look like? How do we share care in an ideal workforce configuration between a physician, a nurse, and other team members, social workers, et cetera? Okay, that was 2. Number 3, you all feeling some competition? I know we are at UNC Health. A lot of competition, especially in primary care from corporate players. And a lot of these corporate players, even before the pandemic, were already redesigning their workforce. They were already using technology. And one of the keys is they're not retrofitting their existing model. They're totally reconfiguring it. They're asking patients, what are your unmet needs for care? When can't you get access to care? How can we hire the workers and deploy the team that can better meet your needs? And so the corporate players were out there, and I predict they will continue to be out there and be disruptors, particularly in primary care. The 4th trend that we saw even before the pandemic was this really important focus on addressing the social determinants of health. And I'm going to tell you right now, I don't call it a healthcare workforce. I call it a workforce for health. That is, in fact, what we are trying to create. Not a health workforce that is only physicians and nurses and pharmacists. We're talking about a new workforce for health, and it's a much broader workforce. It's going to include home health workers, community health workers. I don't know how many of you are employing community health workers in your healthcare system. Community paramedics. Public health, we talked about that this morning, public health workers. Medical lawyers are in the workforce for health. And these integrated behavioral health primary care models are critical. If you think about where you have problems in your health system with beds, a lot of it are going to be behavioral health concerns that you can't discharge, that you have a lot of pressure on behavioral health. And so one of the things that we see in our research, and I've tried to throughout my slides give you references, we've been doing a lot of research on the use of social workers. Traditionally, social workers, I don't know that even social workers would have considered themselves part of a workforce for health. But we've been doing a lot of research trying to understand their roles, and they play three primary roles. They're behavioral health specialists, so they're providing actual behavioral health interventions. They're care managers, coordinating, monitoring, but they're also brilliant at this referral role. If you think about a patient who's discharging, you don't know where they're going, you need help, you need to find a bed in a skilled nursing facility, they are geniuses at coordinating care outside of the hospital, outside of the ambulatory care, and they're playing an increasing role. We're seeing just an incredible increase in the use of social workers. The fifth pre-COVID trend that we saw was a lot of mergers and acquisitions, and you know this. We saw between 2005 and 2016, 12% of rural hospitals merged. I don't know how many folks here are from a rural hospital. Maybe you know a rural hospital that merged. Often the research shows those mergers actually result in better health outcomes, particularly for myocardial infarction, heart failure, and stroke. But we've done a lot of research showing they also can decrease access, particularly for maternal care and surgical care. And there's a great paper in Health Affairs done by some of my colleagues that show right before a hospital closes, who leaves? The surgeons. The surgeons leave first, and that causes a huge hit in terms of revenue. And afterwards, the long-term ramifications is an 8.2% decrease in primary care physicians. And so you're seeing an exodus of your workforce. So I just took you on this sort of pre-COVID tour. And so one of the sort of conceptual frameworks that I want to leave you with is those forces, that continuing health system consolidation, mergers, the increasing number of patients in value-based care contracts, and this growing need to address the social determinants of health are putting immense pressure on you all to reconfigure the workforce and develop new models of care. And I am here as a pointy-head researcher to beg you to collect data on these new team models. You are sitting on incredible data in your EHRs, in other places. Collect those data, help us evaluate the performance of these different teams. And then we can help you and partner with you and to document and disseminate, because we need to understand what are those new models for which types of patients, in which situations are they working. So that was sort of the pre-COVID. Let me switch gears and tell you what's happened. The pandemic has just accelerated all those forces. So we talked this morning about the increased use of telehealth technology, the fact that there was, I think, an unprecedented, I don't think anybody would have predicted Medicare bennies being so wanting to do telehealth. And so we saw this incredible increase in the use of telehealth among Medicare beneficiaries. 47% of patients preferring it, and these dramatic changes from CMS, which may or may not be sustained, also had knock-on effects on the workforce, right? In the short term, our workforce, some folks did telehealth, particularly in mental health, mental behavioral health. But suddenly, overnight, workflows were reconfigured and roles were reconfigured. MAs, medical assistants, and others were learning how to room people virtually, do assessments. We're trying to figure out which patients do we need to see virtually, which do we need to see in person. And I don't think we even understand yet, are providers happier? Are they more satisfied? Has it improved access? Are patients happier and more satisfied? These are the areas where we need better data to help us understand in the long run, with the changes, with what will undoubtedly be an increased use in telehealth, which patients, which providers, how is it impacting outcomes, access, cost? We talked this morning about the unmet and growing need for behavioral health care. So during the pandemic, you know these data solid, I do too. 4 in 10 adults depressed and reporting anxiety. ED visits for overdoses continued and got worse. And it's not only, and we've talked about this morning, and I have to tell you, as a workforce researcher, I've been in this field for 30 years. I have never been more worried about the state of our healthcare workforce, because it's not just the patients who are struggling. We have a pandemic of moral distress and burnout. A 2020 survey of over 1,000 healthcare workers, 86% reporting anxiety, 76% reporting exhaustion, 75% saying they were overwhelmed, 55% questioning their career path. I want to highlight that. What happens when a provider or clinician questions their career path? They may drop out. They're not a very good role model for future. So these are going to have impacts on our pipeline. 39% say they're not getting the support that they need. I want to take you back to some work that's being done by a colleague in my center, Dr. Tanya Jenkins. And Tanya Jenkins was very struck by the National Academy of Medicine report on burnout and the factors affecting burnout. And she wanted to look at the fact that even though traditionally a lot of our efforts to address clinician burnout have been focused on what? The individual clinician, yoga, meditation, a pizza party. Thank you very much. Thank you very much. But we in our center are trying to elucidate the institutional factors that contribute to burnout. And this is hard, and I'm sorry, occasionally I gotta say as a researcher uncomfortable things. We have to look at the way that work is organized. We have to look at the way that models are staffed. We have to look at the way that we portray value to our healthcare workers and the way that they feel value. And the professions themselves put immense pressure on people to live up to the profession, to be, absolutely heroic. And then we have societal pressures. We expect nurses and physicians and pharmacists and everyone to be perfect and to be heroes and to continue to run a marathon. And so we're trying to elucidate these factors at each level that contribute to provider wellness and well-being. And I don't want you to forget that it's not just doctors and nurses that are burned out. We have a study that we're doing of low-wage workers. And these are everybody from your, the orderlies, the certified nurse assistants, and others. They've also had incredible changes in their duties. They are understaffed. They are very worried about contracting COVID and endangering their families. They would like to be recognized for the roles that they're playing. And they're also very unclear whether the benefits that others in the healthcare system, nurses and physicians, are getting, are they getting them too? So let's not forget our frontline low-wage workers as well. And some work that we were doing, actually, this was a scoping review that's I've given you the citation, looking at what hospitals and health systems are doing. Some of these things are going to look very familiar to you, really enhancing communication, having a lot of wellness initiatives, having, again, those individual counseling and support, group unit counseling and support. Goods and services, really important, especially around childcare. We're seeing incredibly, that it's an incredibly important thing to people. Staffing and flex benefits, backup pools, really important. Peer support and adequate PPE. But we're just at the beginning of working with you and others to understand what are these levers, what are these institutional factors that promote wellness and prevent burnout. The Great Resignation. Burnout and shift. So these are data from the Federal Reserve Bank that show over time quit rates. And it's been stunning if you look at the data, stunningly depressing. Nearly 600,000 workers quit in November 2021 alone. Let me let that number sink in. 18% of healthcare workers report quitting their job since the start of the pandemic. And when you ask people about plans, they're burned out. They're ready to quit. They're ready to go. So one of the things that we're doing in North Carolina is looking specifically at nursing. So my 9th trend is I wish I could tell you that the nursing workforce shortages were going to get better. They're not. I'm going to have you go to North Carolina, land of basketball. Someone asked me before I gave this session if I was from Duke. Oh dear, no, UNC Chapel Hill, go Heels. It's okay, my husband's at Duke. But come to North Carolina with me. One of the things that we wanted to do was to create a workforce model where we could understand future supply and demand of nurses. And I've given you the link. It's actually an interactive tool. It's a really fun tool. You can go in and actually customize the geography that you want to see. It's for different employment settings. I encourage you to go have a look. But let me just tell you what's going on in our state, because I bet you it's happening in yours too. Even before the pandemic, let me explain this chart to you. It's a busy chart. The top dotted line is demand. Even if we assume demand is going to be constant, these are projections from 2020 out up to 2033. Even if we assume that demand is going to rise, that there's no pandemic effect, there will be. So you see that rising dotted line of demand. You see that even before we started modeling 3 years before the pandemic, even before the pandemic hit, we were looking at a projected shortage of about 12,500 nurses in North Carolina. 10,000 of those were in hospitals. If nurses retire or exit the workforce, not just retire, just get fed up and leave the workforce 5 years earlier, we're looking at almost a doubling of our shortage in North Carolina. And I will tell you, as a workforce researcher, I thought people leaving 5 years early seemed a little extreme. I think now we might be conservative. I think people might be leaving even earlier. So these are the things that we're looking at. The absolute impact of exit, of resignation, is going to be huge. And I go to the legislature and I show them this slide and they say, more nursing schools. We just need more nursing. We just need more nursing students. And I say, true in the long run. But if you look at, even if we could wave a magic wand in North Carolina and create nursing faculty and create clinical placements, you want to wave your wands with me? It's magic. Even if we could, the difference is so small. Even if we increase enrollments and graduations by 10%, we're only decreasing the shortage by 2,000 nurses, 2,000 nurses. What's it about, folks? What's going to get us out of this? It's going to be retention. Yes, we're going to have to increase the pipeline in the long run, but we're really going to have to focus on retention. The growth in temporary staffing, I know that you're all going to be nodding your heads, yes. We have seen this dramatic increase in the healthcare staffing industry, and the growth in investment has been huge. And those high labor costs are going to continue to negatively impact hospital operating margins. But you know what else they do? They really messed it up for rural communities. Those rural communities were already struggling to get healthcare workers. And you start introducing this temp staff model, and rural is even hurting more, or the rural folks are moving into higher paid jobs somewhere else, or they're going into travel positions. So I really worry about distribution, which was already a problem. So those are my 10 steps. Please take a breath. I didn't mean to be depressing, but I want to charge us. I want to charge us going forward. How do we navigate this crisis and prepare for the next one? We're going to have to think about both the short term and the long term. So in the short term, I need you all to help me figure out, what are those retention strategies that are working? What are those new models of team-based care? You're never going to have enough bodies right now. So how do you redeploy the bodies you have? How do you redeploy the bodies you have into different models of care? In the longer term, you can't do this alone. You're going to need to partner, and some of you already are, with academic partners to secure that future pipeline, whether it's for nurses or physical therapists or physicians. And as I said, it's not just the numbers. You're going to have to partner with academia to say, are they trained in the models of care? Are they doing pop health? Are those nurses have enough behavioral care, et cetera? You're going to have to partner with those community partners to address the social and behavioral health needs. And please partner with us researchers to build the evidence for new models of care. Because the message I want to leave you with is, instead of putting that old ship together and assuming that we're going to just keep doing things the way we've always done things, we're going to have to reconfigure these models and make systems and the workforce more resilient in the future. So that's my message of partnership going forward. If you want to contact us about any of these studies, et cetera, I'm happy to share them with you. Our center does focus on this, and happy to partner with you going forward. Thank you very much for having us.
Well, that was a wonderful presentation, and thank you so much. As I reflect on the morning, it's just as AHA is wont to do, it's all been set up beautifully, but hearing you talk, I have a couple of questions. An easy one. You showed us trends.
Yep.
What are your predictions? Where do you see healthcare going?
Yes. I do see healthcare going more towards the use of teams. I think one of the things you're going to increasingly see is an increased use of social workers to address those upstream social determinants of health. But I also want you to concentrate on your therapeutic workforce, your physical therapist, your occupational therapist. I do predict we're actually going to need to focus on that workforce that's keeping people safe and healthy in their homes. I do think workforce shortages are going to continue to plague us. But I do believe that value-based care is going to force us to reimagine the workforce. And how do we do that? We're going to have to ask patients, what do you need? What are you not getting? And please ask providers in your healthcare system, how could we redesign the care delivery model to make it better? So I predict there will be more team-based models of care because we're never going to have enough bodies.
Well, I know my own team has been rethinking workflow and trying to identify how best to support our existing team and current practice. But, what are some of the pitfalls you think we should keep in mind as the field starts to rethink roles to support different care models? To your point, all kinds of different people becoming part of the care team.
Right. I think anybody who's worked in healthcare workforce for 30 years knows there's some third rails in workforce, namely scope of practice battles, and those continue to be an issue. And I would say, trying to refocus people towards the patient, and really what is the best patient, the best care for the patient, what is the best team for the patient. I think payment models will continue to plague us. We are still in a system that rewards billing providers, physicians and others. We're going to have to look at really understanding the value of nurses. There's some great new literature coming out trying to define the value, the value of nursing care in value-based care models. So I think payment regulation, but I have to say, for me, one of the biggest barriers is training. Our training system is really not producing, and I hope that you all, in some cases it is producing the product that we need, but in many cases it's not. And so I think moving forward, hospitals and health systems and others, we're really gonna have to make sure you're articulating what you need so that you can change payments, you can change regulation, so you can work with academic partners to reconfigure and realign training. So those, to me, that three-legged stool of payment, scope of practice, regulation, and education are critical.
And do you see us needing to reach further down? And, we talk about talking to high school students and college students, but aren't we really going to need to reach down into middle school and to begin to talk about the types of roles that we need? And how do we do that?
Yes, so that's a really important point. Developing that pipeline early, many students, even by middle school, have already made up their mind about what they want to be. And remember that statistic that I just showed you with 55% questioning their career path? We're going to have to really find role models to be able to work with students very early on in middle school to expose them to really exciting models of care, to caring for patients. I don't know if you all remember, after 9/11, there was this hero effect, where we saw an uptick in people wanting to be fire people and police people. We may see that, and we may need to leverage that to say, yes, this is a heroic field, healthcare, and we need you to go into it. But one thing I have not talked about this morning, and shame on me, is we are never gonna have achieved an enhanced health equity unless we diversify our healthcare workforce. Our workforce does not match the diversity of our patient population. So as we're reaching down the pipeline, we also need to be looking for partners to help us diversify our workforce, to be able to create career ladders, to be able to allow people like licensed practical nurses, who are one of the most diverse health professions, to go on to become registered nurses, to become advanced practice nurses. So those are some of the things that I think we need to be looking for in the future.
So where is your research headed next?
I just put in a proposal, fingers crossed, to do a couple things. I'm really interested in your changing workforce. So I'm interested in understanding how the hospital healthcare workforce has changed over time and just being able to describe that, because I think it's incredibly important if you look at the percent of our healthcare workforce that's employed in healthcare systems. I'm very, very interested in the safety net, the roles of community health centers and the roles that they play in your communities and those partnerships. I'm really interested in the role of community health workers, What is the role that a community health worker, who's sort of a liaison between a community that tends to have access to care issues and a healthcare system? So our center is going to try to do what we did for social work, which was to elucidate roles of care, and we're going to do that for community health workers, trying to understand the way that they impact cost and quality. We're also looking and want to look at the roles of historically Black colleges and universities in our country in diversifying the healthcare workforce. So those are some of the things that we're really interested in, broadening our understanding of who's in the healthcare workforce and how to build these teams.
You know, knowing, and you referenced this, how existing challenges have really accelerated. I mean, we really do have a perfect storm in this country in terms of an aging population, changes in consumer and worker preferences, and a seemingly explosive demand for team members. What are the next trends you'll be looking into, and what should we be thinking about?
Yeah, so one of the things that really interests me is understanding career paths. And I think one of the things as I partner with you and others is to look at a health career trajectory. What, for example, let me just use nursing. What a new nurse needs to feel supported in the workforce, a transition to practice program, maybe loan repayment. It might be different what that nurse needs mid-career around retention, childcare, perhaps tax benefits. And then recruiting that older nurse, maybe she's tired or he's tired of working at the bedside, so how do we get and retain that knowledge? So I'm really interested in sort of understanding career paths and what are the things that hospitals and policymakers can be doing along the career trajectory. I think a lot of our policy interventions are really focused on loan repayment and getting people into the healthcare system, and then we assume they're fine, and they're not. And I think COVID's shown us that. So what do we do going forward to support them throughout their career trajectory?
And just one last question. We are actively at my organization working on reinventing how we deliver care and a workforce plan. And one of the things that we run against is, well, we don't have the data.
Right.
And we may know the data of who we've retained and who we've lost and the demographics of our workforce, but you said we have access to lots of data.
Yeah.
What are the 2 or 3 most important data points that all of us could go home and say, gosh, we can find these?
Oh my gosh, give me your data. So one of the things that we're seeing that I'm really excited about, I've mentored a number of Ph.D. nurses, and actually a bunch of our healthcare systems have hired them. And they're using your electronic health record data to understand what's happening and what what kind of care is the patient getting. The problem with an EHR is a lot of the care that the patient gets from a social worker or a nurse is in the note and not in the EHR. So one of the things we're trying to do is create methods to be able to use things like machine learning to grab that data and pull it out. But if we could combine your EHR data with your FTE data and really understand who's providing the care, what does that model look like, and how is it impacting cost? Cost's really hard to get at. Access, quality, these are things that you have. These are data that you are sitting on, your hospital or health system is sitting on these data. You have both the who's providing the service and what service they're providing. Because often that's a black box for healthcare researchers. We know who's in your hospital, but we don't know what they're doing. So it's going to be a combination of quantitative data, but I would also encourage you to partner with researchers to do qualitative data analysis, to really understand roles. Like what's keeping a model of care from not working? Is it a turf battle? Is it that I don't know your role? I'm a physical therapist who doesn't understand the role of a social worker. So I think it's both things. It's the quantitative data that you sit on, but also the qualitative data that you could leverage because you have access to the incredible healthcare workforce. And we do want to partner with you as healthcare workforce researchers.
Thank you so much for your time this morning.
Thank you for having us.
It's been a wonderful presentation and an incredible context for us as we continue. Thank you.
Thank you. Thank you.
Part 2 is coming. Welcome.
Thank you.
So now on to part two of our workforce discussion. And before I introduce my colleagues here, one of the things that I'm always impressed by is the depth of experience and competence of our AHA board members. And both Ron and Mary Beth are AHA board members, and it is always a pleasure to highlight our colleagues at these meetings and to really pick their brains in terms of what they see. And that's exactly what we're going to do for the remainder of this panel. Mary Beth Kingston is the Chief Nursing Officer at Advocate Aurora Health. She leads nearly 22,000 nurses in Illinois and Wisconsin, and I suspect she would tell you she'd like to have that number increase. In that role, she's responsible for nursing practice, standards, education, research, workforce in all care settings. She's past president of the American Organization of Nursing Leadership, a current member of the AHA board, and the chair of the Hospitals Against Violence Advisory Committee. Her fingerprint remains on many field-wide programs and initiatives that prioritize diversity, education, and patients as a key to leadership. Our next panelist is Ron Werft, who's the CEO of Cottage Health in Santa Barbara, California. He chairs the RPB Region 9 and serves on the AHA board. Ron also chairs AHA's newly formed Workforce Task Force that has an easy job. It is tasked with identifying and disseminating successful practices and resources for the field and shaping AHA's work going forward as we again continue to tackle what we just heard will be long-standing and far-ranging workforce challenges. We will have an opportunity after this panel to take questions from the audience, and I will give you the how we do that when we get closer to that time. So, welcome.
Thank you. Nice to be with you.
And I'll just start with an easy question. I know that you all share my concern that we can't keep sprinting. We have been sprinting for the last 2+ years, and we simply cannot continue to do it. We need people to stay. We need people not to burn out. And the pandemic really accelerated aspects of what our staff must do, and that works for a week, but not for years. So let me start with a question that I will ask each of you. What are you doing to drive retention right now, and how can we keep who we have and keep them thriving? Mary Beth, I'll start with you.
Sure. Well, it was very interesting to hear Erin's insights. I think that, we look at why nurses and others are leaving healthcare. And, our short-term solutions have tended to focus around compensation. Compensation doesn't head any of the list. Staffing heads the list, workload heads it, as well as just the emotional toll that we've been seeing. And the interesting thing when I was listening to the statistics is that we are seeing people in their later years leaving, but we're really seeing that first few years, like first year to third year. That's where the turnover is occurring. The implications of that moving forward, decade after decade, are really significant. So a lot of our efforts are focused right in that beginning area. Most of us have residency programs, but I think more frequent touch points and support of those newer nurses who started in the midst of COVID and really did not, as they signed up to go to nursing school, did not quite sign up for this, is really, really important. A couple things that I will say about comp and benefits, what we're learning. I believe we've got to segment our comp and benefits. We tend to have a one-size-fits-all. Some places do segmentation beautifully, but the 21-year-old is not interested in the same things that the 56-year-old is interested in. For example, and they're in the driver's seat right now as they're interviewing with us or talking to us about where they're going to go. And folks are saying, I'm 24, I can stay on my parents' insurance until I'm 26. I don't want your insurance. I would like to have those dollars instead. The 56-year-old is saying, I'd like to see additional dollars put into my 401k as I near retirement. So looking at what each person needs and wants and trying to tailor our comp and benefits to that is important. The other areas that I will highlight, staffing is a huge issue. So when we talk about these models, it's got to be reducing some of the workload for folks. It's got to make their job easier. So some of that comes in with the model discussion in looking at how can we decrease just, and it's not always big things, it's those day-to-day annoyances, the redundancy in charting, the effectiveness, the efficiency of the work that we do. I think we have to relook at productivity and how we're measuring that. So many of the things that we need to do to build stickiness with our system and build the pipeline may require us to bring people into our organizations. And a lot of times I'll hear nurses say they're reluctant to do X, Y, and Z because of productivity, or they don't feel that people are seeing the value of some of the things that aren't measured in productivity, such as interacting with a family that needs a tremendous amount of time. And the last thing I'll say, because I mean, I could go on about this forever. I have 2 more things I'll mention. The work environment. I mean, we've got to address the work environment. We've talked, I've talked about staffing, we've talked about the mental health, but workplace violence has to be addressed, and it has to be addressed in a very visible way, with training, with technology, whether it's mobile duress buttons, but that issue comes up time and time again. And not just violence with patients and visitors, but the potential of interprofessional violence, bullying, et cetera. And the thing that I think we do really well at our organization is engaging all folks, nurses particularly in my case, but all of our team members in their work. And so getting back to these shared governance models that many people put on hold during the pandemic, people need to have input and impact into how we're changing models, what the work environment looks like, and they need to feel that that input is valued. I don't know if my boss, Jim Skogsberg's in the audience, but he will call me and ask me to check with the shared governance leaders for their input on various topics. And you can be assured I let them know that the CEO is calling me to get their input on this. So they're just a few of the things that I would put forward.
Ron, before I let you answer this question, you triggered something that I wanted to just mention as you talk about all of the things that make up work that happens on a nursing unit in particular. And we at St. Luke's have 4 pilots that are just about to kick off that were designed at a unit level to look at how we might redo work. And we had a whole analysis, of course, part first, and we found that in one of our med-surg nursing units, standard med-surg level 2 nursing unit, that 319 minutes over 5 hours per shift were spent by nurses and nursing assistants ordering food. We have 52 diets. We have multiple choices in those diets, and if anyone is tired, sick, or confused and doesn't have a family member at their ready who has patience, it falls to the nurse, it falls to the nursing assistant to order that food. Now, food is important, but is that really what we should be using a scarce resource to do? So I think this is in some respects very granular work. Yeah. I'll turn it to you to answer this question.
Thank you, Dr. Estes. And may I call you Dr. Estes and not COVID chair number 1? Okay.
You could even call me Mindy. That might even be better.
Just really resonate with everything that you said, Mary Beth. I'll just share a few observations from our own organization at Cottage Health, and then I'd like to talk a little bit about the work that the task force is embarking on. So just if you kind of break down in our organization, how we're tackling this, maybe describe it in 3 categories, and one I just would describe as basic, and that would be, compensation and benefits, and I think those are basic table stakes. We have to all make sure that we're providing competitive compensation and benefits, and I mentioned that one, even though we're all aware of that, because I think it's going to be harder and harder with the supply and demand imbalance that we have with the impact of contract labor. There's going to be a lot of pressure on the compensation side for us to continue to invest generously into that side just to have a chance of staying where we are. We're remarketing all of our benefits that are maybe a little unusual. We have commuter benefits. About 25% of our workforce travels a long way to get into town because of the cost of living. We have housing support that maybe not all of the new employees are aware of, so we're remarketing that. During the pandemic, we tripled. We have preschool childcare on campus at our largest hospital, and with school closures and preschool closures and all that went on with that, we added 2 others in the community. And we're just going to keep those going because it's been a need in the organization for a long time. And this is about listening to your employees and really finding out by generation, what their needs are, and obviously very different from those who are within that 5-year window of retirement, what they might be looking for. Second category would just be increased flexibility. I would say more openness to part-time opportunities than we used to have, because you're now choosing between somebody going from full-time to part-time or full-time to retired or resigned. And so making sure that those coveted ambulatory positions also are well known to people who might be within that window of leaving. And I think the reassignments during this pandemic have opened a lot of our staff's eyes to other opportunities within the organization that they might not have thought of before. We'll get to the issue around pipeline and academics, but I'll just mention here that having our more senior RNs either go part-time or maybe full-time it's not a loss if they become faculty at the local nursing program. It's not a loss to all of us if that's what happens, and they can stay in our larger system. And then I think the one that you hit on last is really, to me, it's the most important part of the stickiness, and that's engagement and culture. We've had a robust system of shared governance beyond nursing throughout all of our hospitals and throughout our organization for about 20 years now. We have unit-based shared governance councils. We have a coordinating council, and they're very, very active. But this year, we, in our board-approved top goals that included burnout, well-being, I'll tell you, our nurses are advising us to not use the term burnout any longer because it's sort of self-perpetuating. And so to really talk more about well-being and wellness. We have some top goals around that. We have some top board-approved goals in DEI as well, both within the organization and in the community, and on workplace violence. And so we've delegated a number of those initiatives in all those areas that have real meaning to our workforce to shared governance councils. And we've got a long track record of implementing almost, if not every recommendation that's ever come out of that. So what's interesting to me is that they come up with ideas that sometimes cost money and more often don't cost a lot of money. And so, things that came out included things like paying for the premium column app for everybody to get at just minor way of helping with stress management. Some things that did cost money were increased security. We have canines in our hospitals, and so we have more dogs than we used to have and more security officers as a result of that recommendation. I think one of the best that came out of the Shared Governance Council on Workplace Violence was the canine increase, but also a kindness campaign where we've got posters in our elevators, in our lobbies now, and in the ED that shows a nurse a picture of a nurse in scrubs or another caregiver, but also that same person as a soccer mom or in hiking clothes or in a softball uniform. And they're side by side, and it's just reinforcing that these are real people. And I don't know that is going to decrease workplace violence in our ED, but it came from staff, and they love it. And we did a drive-in night locally. We did that during COVID. We have the drive-in theater movies for our staff now. And I had a nurse tell me that when she took her family to drive-in night, we showed that before the movies, and her kids said, "Look, mommy's a movie star." And so I mention these things because I think this engagement, no one of these is going to make a difference in retaining staff, But the fact that they all came from our workforce and we implemented all of them, they just really feel vested in the place. And so now when we get to the task force, that's more important than what we're doing at Cottage. The task force is just starting its work. First of all, huge thanks to Rick Pollock, to Michelle Hood, the whole team, and to the AHA board, really for recognizing the urgency of this issue and appointing a board-level workforce task force to get at it. There are about 15 of us. Mary Beth and I serve on the task force, and it's multidisciplinary. We have physician leaders and nursing leaders. There's a strong representation from AONL. We have CEO, executive leaders as well. And we had our first meeting in February. We're meeting on a monthly basis going forward throughout the year. And we've developed our objective is, as you said, Mindy, our objective is really to develop and convey to the field data, resources, best practices around delivery systems, care models, and also ideas about regulatory and legislative changes that might be needed to support some of these things, to really collect these and get them out to the field as quickly as we can. It is a big job. We're modeling a lot of our work after your Pathways to Recovery effort, and in that vein, we're not waiting for a final report. As we have information that we think will be useful, AHA will be getting it out to the field. We got a lot of great insights from all the RPBs at this last session, and I would say importantly, we'll do very little duplication. There's a lot of work going on in this arena right now, and so we have a lot of collaborating partners on this. There's great work going on at AONL. I think 26 or more of the state hospital associations have their own robust efforts in this regard. So a lot of collaboration to make sure that we get best practices. And among the deliverables will be, you mentioned that you're doing pilots on care models on the units. And so that might work in your other hospitals. It might not. It might work in our hospital, right, and it might not. But I think it's important to share those best practices as soon as we possibly can.
Agree. Let me just ask a couple of fairly granular questions before we come up to a little higher level, and I think they're practical things that a lot of us are dealing with. How have you addressed the challenges that have come in with bringing in travelers and contract staff to address our short-term workforce challenge? We did what we needed to do, and overnight our contract workforce has gone to levels never seen before. How are you addressing those challenges? Ron, I'll start with you.
Yeah, I think it's a challenge. It's every meeting we go to, we hear about the percentage of our workforce that's now represented by travelers, by contract labor, and we hear even more about the cost of that. So I would say at a start, there really wasn't a choice on this. If we're going to be there for our communities, we have to staff our hospitals. So we really didn't have a choice on this. I think for us, it led to one of the ideas being retention bonuses and stay pay, and that kind of conversation became more prevalent in our institution. So in terms of how we are dealing with it, we may be unusual in this regard, but I think for us, because we're somewhat geographically isolated where we are, and we do have historically very strong retention in our hospital, it's not been a bad thing to have some level of travelers coming in to tell people it's not so bad here. And so that's been a benefit over the years. We have too many of them right now, and I don't know that I have a really good answer for how we've dealt with it, other than just felt like we really are dependent on it and have to do it.
Mary Beth.
Well, I mean, there's certainly I would say, I don't want to say resentment, but the issue of what people were getting paid and working side by side. Of course, I think we all shared that issue. That was a huge issue. But on the other hand, we've had a lot of conversation about how contract labor and travelers they do serve a purpose throughout, no matter what's happening, whether we have an increase, a new program, or sudden decrease in staffing. We've always been able to utilize that. So people are familiar with the benefits of that. The larger numbers, I think, has been the issue. Most of our team members have been happy to have help and the assistance, so that's the positive. And we also did some compensation pieces to make it a little bit more equitable. I think the thing that I am hearing more about is we don't have data, and we haven't really studied the impact of having very high percentages of people in our organizations who are not part of our team. So who haven't gone through all of our safety training, for example, and aren't as engaged with our organization. And I think that's something that we're going to need to be studying. I know the IHI is looking at that right now, and working actually with some of the agencies to say what can we do on that front. We've all seen, I shouldn't say we all, many of us have seen difficulties in our metrics and our quality metrics over the last 2 years. We can't tie that to anything specific, but we do need to understand what has caused that, whether it's just the stress of the workforce or are there other factors involved.
Yeah, we've seen a number of our nurses who have left us to go travel, and I think as many of us have seen, they didn't have to go very far.
Yeah.
They went across town. So they stayed, they stayed at home, went across town. Compensation double, triple in some instances. But as those rates are beginning to come down, we have actually seen a great number of them, I think 95 or 100, come back to us. And that in itself poses a different challenge as well, because you walk back in the door, we're glad to have you, but many folks on your unit didn't forget that you left. And so I think we'll be continuing to manage that.
And I think that the whole issue of the work environment is, again, what leadership keeps people here, the support they receive from their team members. So when you have that disrupted, you have a support system that's disrupted as well. And I think people want to come back to that. We had so many people say to us, I don't really want to leave, but I cannot pass, you look at the hierarchy of why people leave, and comp and benefits tends to be at the lower end, but when the delta of what they're getting paid is this big, they just say, I can't pass that up. So as the rates come down, I think we are going to see more people come back, and many organizations have done an internal agency where they've decreased the middle payment and been able to pay people. We call them saves, a lot of people who said they were leaving, we could get to them and say, hey, we have something that we could offer you.
And Mary Beth, I'll start with you, as you're the chair of the Hospitals Against Violence group. How are you addressing the uptick in violence and incivility? I mean, it's being seen across society in general, but the impact that it has on already tired healthcare workers.
Yeah, I mean, we have an all-out effort there, really partnering with our safety and security colleagues to do all types of, first of all, I think it's letting people know that everyone recognizes it, and we're going to do something about it, because I think for years it wasn't something that had as high a profile. Many organizations we've talked about how we're looking at different states and making this a felony or making it, increasing the penalties. I think that's, again, more of an awareness. It's an important piece, but it doesn't really get to a lot of the issues. Signage and things like that, great, it sends a message, but what can we really do? We've got to get to the prevention of it. I mean, we have a lot of things that we talk about, supporting staff afterwards or having behavioral emergency response teams, all really important. But how are we giving our team members the skills to be able to see the potential of a situation and de-escalate it before something happens? And that is a skill, and it can be taught. So I do think that's a key thing. What behavioral health supports do we have in place? And it's not only behavioral health patients. We know we're caring for people at their most vulnerable and families are upset, but we should be able to have enough support to develop plans of care and be able to anticipate that certainly someone who's been violent before, or have been aggressive before may do that again. And I think the way we're framing this, as we do all kinds of threat assessments and prevention work, is to say it's not just, it is about keeping our team members safe, but it's really about creating a safe environment for everyone. And that includes our patients and families, because when you see violence in the workplace, it disrupts everything. It's stressful for everyone. We lose people to the profession. And I just think that it is one of the most important issues we have to address in terms of the work environment right now.
Right.
Yeah, really agree with everything that you said. It's become a real high priority for us, and I'm sure everybody in this room shares that. I do think having robust systems of threat alerts and the ability, we certainly have added significantly more psychiatric support in our emergency departments as a result. Having crisis stabilization units that allow you to provide a safe place to move people who may be a threat outside of the ED, and not only protect our staff, but get the care that they need with both ED and mental health professionals as quickly as they can de-escalate this significantly as well.
Yeah, and I think using some of the technology that we already have, we have an electronic health record which should enable us to flag patients that we know have been violent in the past or who have been abusive. But yet when we did a little look across our organization, we didn't use it consistently, and even if we used it, we ignored it at times. And so to put in the steps that if you see this as a care provider, what do we want you to do? What can you do? I mean, you don't go into that room by yourself. I mean, a whole host of things that seem to be a no-brainer, but in the stress of the moment, everybody's busy, hospitals are overwhelmed, that we haven't used what we have available to us.
Right.
Let's pull up a bit and think longer term. How are you reorganizing and rethinking work to create space for your team members to stop being on high alert every minute of their day? And have you seen any technology that would help reorganization of workflow or that would help this problem? I'll let whichever one of you want to start with
I'll
that.
let Ron take that.
Yeah, well, I think we've been under fire for so long, for 2+ years now. We've only recently closed our last isolation unit. We've only recently gotten back to full OR schedules. And so when we think about high alert, I would say we're down to maybe DEFCON 3 or 4 at this point. There's red, yellow, green, but there's I think on a high alert scale we're still pretty high on that. And so it's been said in every meeting and by Dr. Fraher as well. Every session that we've had, we've talked about what our staff have gone through these last 2 years. But I think it's not just what has happened in the last 2 years, from PPE to setting up testing platforms where testing didn't exist before, to figuring out negative airflow and opening, closing isolation units. Then vaccines, and then vaccine mandates, and then religious exemptions. I mean, it just goes on and on and on. We still have an incident command every week. And so it's down from 7 days to 5 days to 3 days to 5 days to now down to 1. But there's still plenty to talk about every week. So there is still a bit of a high alert in the organization. And, all of this has come at a time when our staff have faced also incredible personal challenges of school closures and had to figure all of that out as well. At the beginning, changing clothes in the garage before they walk in their house, or maybe staying in an apartment if they're doing 312s, that sort of thing. It's just been an unbelievable demand. And frankly, we've asked more, and society have asked more of our staff, caregivers and support staff, than really should be expected of anybody. And we're paying a price for that. We have burnout, we have stress. You saw the statistics a few minutes ago. And as a result, we have retirements and resignations and high turnover. I think, one area that's, I think, important to talk about is what I used to refer to as our middle managers And thank you, Dr. Rod Hochman, for teaching us that there really are core managers, not our middle managers, there are core managers. And so, these individuals are frontline clinical managers, the head of EVS, all of these staff. They've had 2-a-week management calls with every one of those had some change that they had to implement with their teams as they supported their teams. And many of them didn't get a break of any kind for a year or more. And they're starting to get that now. But I would just emphasize the importance of supporting those who support our staff. Because when staff either stay with an organization or leave an organization, oftentimes it's because of their affinity and their relationship with their supervisor, certainly more than it is with my office, and more than it is with the name of our organization. And so we had a tragedy a few weeks ago when one of our very best med-surg nurses, nursing clinical managers, one of our very best, who is probably is mid-career, I would say, and just loved by her team, just made the decision, I can't do this any longer. Even though we're down to almost no COVID patients, she just said, I just can't do it. I love this place. I hope to come back, but I can't do it any longer. And so I feel horrible about that, because I think that the need for us to support those people who are looked to by their staff for support is just a really, really important thing for us to do.
So, with care models, and we talk a lot about care models, I don't know which example I give. There's no easy button, there's no silver bullet. I think that's the issue, and there's not a one-size-fits-all. I mean, everyone that I'm aware of really experimented with or implemented team-based nursing at some point during this pandemic. And what we found is people were not really ready for that. I mean, we had people coming in and they weren't sure what their role was. I mean, we worked very hard to have a special program that people weren't used to delegating. They were used to doing things themselves. So I think we have to explore that and really give people the skills in a very thoughtful way to be able to do team-based care. And our speaker talked about that. And I do think utilizing all members of the care team in a different way is where we need to head. But it may look different for different populations, different units, and different care providers. So I think I learned personally that lesson, that some units implemented it really well and others didn't, and it didn't apply to some either. So that's one model piece. The other lesson I think that we learned is we did pull in nurses we called it non-patient facing roles, but even from the ambulatory site into the acute care area. And what we found is that some people were not thrilled with that, but we found that some people really reconnected with their clinical base. And I remember being in one meeting and one of our lead professional development nurse said to me, what we need is a National Guard that we can call up, a National Guard for nursing. So we're implementing that. We have a whole cadre of nurses that have moved into different non-patient facing roles. And they've said, what? We would be interested in keeping our skills current and coming back to help in the case of another emergency. And then we have a whole group of nurses who also just said, we'd be interested in keeping our skills current. So what we're doing is developing a system where they have to obviously work with their supervisors and leaders and core managers. But they will have periodic time that they spend in clinical practice. So they might be they might work in informatics, for example, but once a month, maybe it's critical care, maybe it's med-surg, they will work in that area. And they'll work in the same unit so that should we need them again, we would have them connected to that unit and ready to go. That's one other lesson. So I think we have to study that and get the data, as our speaker so eloquently said. But the other piece that we looked at is if we can't increase the supply, can we decrease the demand? Mm-hmm. So, are there ways, and whether it's hospital at home or having a nurse practitioner that's unit-based that can work on length of stay, real time with orders and working with the hospitalist. Are there ways that we can move patients more quickly or have them at a different level of care so that if we don't have the supply, that the demand is decreased. So there's some of the areas we focused on.
Yeah, thank you. Yeah. One more question before I open it up for questions from our audience, and I want to end on a positive. So could each of you share a story about something that, fed your own resilience and well-being in the midst of 26 months of pandemic?
I have to think about that.
I'm trying to pick which one. I had an experience at our drive-through clinic where it was the first day that teenagers could get vaccinated. And so this car pulled up, and there was a father and son in the car, window rolled down, and I just asked the 13-year-old young man, why are you excited about today? And he said, after today, I can hug my grandma. And so that was a good moment. Mm-hmm. Yeah, that drive-through clinic, we got our community to 83% vaccination rate with our drive-through clinic. And so it was
Congratulations.
It was a home run. Yeah, it's a home run.
Yeah, I would just say it's mainly when rounding at the different sites where people are very open about sharing the difficulties, the challenges, the trials they went through. But, and I think we heard this today too, where people we saw it on the video, where people have said, I am here for a reason, and as difficult as it is, I'm going to support my team members, and I feel like if I wasn't meant to be here, I wouldn't be, and I'm going to just give it everything I have. And I would hear that over and over and over again, and I got tremendous strength from that. Yeah. The other areas was to watch how the different teams came together during the incident command, and how no one was worried about hierarchy and who was, in charge and all of that. Everybody just said, "I'm here to do what needs to be done," and the incident command team, which wasn't always our most senior leaders, we just laid it out and people just went with it and rolled with it. And then to have to go back numerous times and say, well, that is what we said yesterday, but today that's changed and that's different now. And for people to accept that and say, we know you don't have all the answers. Those were just some really refreshing moments.
I have to say that the incident command experience has been really the most satisfying, rewarding, professional aspect of my career I've ever had. We had brilliant infectious disease physicians there telling us what needed to be done, and they had tremendous respect for those who could execute it, for the administrative staff who could execute it. And so it was really the best physician hospital administrative partnership that we've seen, when we could figure out in a week how to do 3D printing of face shields. And then the discovery of talent you never knew was in your organization that rose up and just said, how many times told us, we got this. And at the next incident command, they got this. So that was pretty amazing.
So let's shift and take some questions from the audience. I believe we have handheld mics, and so I would invite questions. And if you would tell us who you are and where you're from, we would appreciate it.
Good morning, Dr. Estes, and thank you to the panel. This was an incredible presentation. My name is Tom Yackel, and I'm president of MCV Physicians at Virginia Commonwealth University in Richmond. First, I wanted to share a story that was incredibly inspiring to me, and that was on the front page of the Richmond Times-Dispatch a few weeks ago. There was a story about prisoners who were taken care of by nurses on our prisoner unit that we have at VCU. And they were writing stories of thanks to the nurses for taking care of them during COVID. And I thought that was just absolutely inspiring, that those folks would be so grateful that they would take the time to recognize our nurses. It's probably the best story I heard throughout COVID. My question for you is about teamwork and team-based care and just in general working on teams in healthcare. I was fortunate enough to be able to go back and get an MBA a few years ago, and as a physician, I realized I didn't know anything about teamwork. I thought being on a team was what we did on rounds every morning, and I was the captain, and everybody followed me around, and everybody had a defined role.
I'm glad you said that.
And the way I run a team is I write orders. Right? I order people to do things. I order nurses and pharmacists and techs to do things. That's not at all what being on a team is like. How do we disrupt that model for healthcare and say being a team is actually showing up, figuring out quickly what does that team need from you that day, which might be different than what your role was yesterday, or perhaps you have other ideas on how we further develop our notion of team in healthcare. Thank you.
Yeah.
I'll start and then you can jump in. But yeah, it's interesting because we had a team-based model that sort of unraveled a little bit in a number of our sites where we had the hospitalist was, and again, I'm talking in the inpatient setting, and we haven't really talked that much at all about the other areas, but I'll focus there for now. So the hospitalist and the nurse, they had very specific times where they were together rounding and communicating, and the hospitalist would get the shift report along with the nurse. So, there are ways, I think, geographically to structure it, because what happens now, and there's wonderful things about the electronic health record, I'm not knocking that, but the fact that people can be in all different places and trying to get the care, that they're not talking to each other. I think that's a big piece of it. I had an ICU nurse say to me that my role, I used to feel that I was in the coordinating role, so that I was kind of the point for which the team came together, and I would talk to everyone, and we would figure out the plan of care. And now I get orders pop up in the electronic health record, and I feel like I've just moved into more of a task orientation. So I do think that, again, there's all different settings where we practice, but I do think in the inpatient setting, we can certainly structure more communication among team members. It starts with understanding each other's role, what each unique discipline brings to and it's not just nurses, doctors, physical therapists, and pharmacists. It's the environmental services team. When people feel a part of that unit, everyone knows everyone's role, and you're working together. It's a beautiful thing to see when that happens. I think one place that I worked in the past where I saw that was when I worked in an emergency department. It was just, everyone was there together, and you could see that communication on a regular basis.
Yeah, I would agree. When we just look at engagement across the system, it tends to be those areas of our hospitals where we have full-time physicians and full-time nurses and therapists, and this sense of team is very clear. The benefits of that in the ED and the NICU and the ICU setting, very different from our med-surg units, where a lot of physicians come and go, and maybe you have hospitalists managing most of that, but it's still, it's not quite that same team sense. I just, a bit of a segue on that, from that question, if I could, is that, and it speaks to one of Dr. Fraher's slides. I'm sure that she knows of her colleague, Dr. Tate Shanafeld at Stanford, who was at Mayo before that, but his research is in burnout, and particularly physician burnout. And one of the findings is that if you can get 20% of your work time to be what you define as meaningful work, you dramatically reduce burnout. 30% doesn't change it that much. And so if you can just find 20% of your time in doing that. And the other aspect of this is that the benefits on addressing that same issue of social interaction. And that it doesn't necessarily have to be teams at work. It's a lot of that is opportunities to share your rewards and challenges with your peers in structured settings. But I think the more that we can support and develop and promote teams in our systems, it's going to address retention, it's going to address issues of well-being in our organizations as well.
Is there another question out there? I think I see maybe over in that direction.
Right here, please.
Here.
Is that okay? Good afternoon.
Thank you.
Good afternoon. Great discussion, really important topic. Something that we've been thinking about, obviously, in higher education as well. I'm Dan Gentry, President and CEO of AUPHA, the Association of University Programs and Health Administration. So I represent the 249 undergraduate, master's, and doctoral programs in our field for healthcare management and health policy. But AUPHA is also part of the Federation of Association of all the schools of health professions. So the 17 of us, medicine, nursing, and pharmacy, we meet every month. Not a meeting goes by that we don't talk about this issue. What's come up recently in several presentations, and I know this is included in Dr. Fraher's data analysis as well, is the upcoming demographic cliff, where between 2025 and 2030, we will see a 15% decrease in the college going age cohort. So we've got that to deal with as well. Within a few years after that, then obviously folks getting advanced degrees. I'm wondering if there are things that you've been doing, the three of you as leaders, in your own communities with educational organizations to address this issue that we can scale up on a national level. AUPHA's been in partnership with AHA for 74 years. I know AHA has partnerships with the other health professions. Are there things we can do at the national level that you've been doing locally?
Great question. I'll just tell you what we're doing locally, and I know it's happening elsewhere in California and elsewhere in the country. This summer, we're hosting a workshop, an all-day workshop with the 10 university and college presidents in our area of schools that have healthcare career programs, and the CEOs of all the hospitals that are in that same three-county region. And it'll be the first time that we've had a conversation as a region around workforce planning and faculty program master planning on these campuses as well. And I'm hopeful that this will lead to additional collaborations. Each of us have our own collaborations with one or two schools where we support these schools, and most of their grads come to our organizations. But I think we need to think bigger than that and not think of it as a loss if a graduate of a program goes to another hospital in our region. If we're working together on this, and as you well know, the schools are having their own workforce challenges as well. The inability to fill some of these programs is not due to lack of interest on the part of applicants. You heard the reference to 80,000 RNs, or RNs, people who wanted to become RNs were turned away in 2020. So I think the promising side of this is that we have huge interest in going into these professions that have incredibly meaningful and rewarding work. We have got to address the structural challenges that are limiting enrollment, and we're responsible for the part of that has to do with clinical rotation shortages as well. So I'm hopeful we can find collaborations with our universities on a regional basis, because if we have, I know that staff who grow up in our part of California and are educated locally and come to work for us, they're with us for a long time. And so it just makes sense for us to invest in that effort.
I am going to take the moderator's prerogative here, because you all have been very attentive for the last hour and a half, and I appreciate, and I know this is a topic that I hope we all have gotten a few ideas today. I would like you to join me in thanking our panelists for really a terrific discussion.